Hello everyone. I'm really happy to welcome you all to this third BeSP symposium. I'm Elina Renko. I'm from University of Helsinki, and I'm a postdoc researcher at the Faculty of Social Sciences, and also coordinator of this BeSP program. And well, the point of this BeSP is to evoke interdisciplinary discussions and on questions related to influencing behavior, and also seek novel, promising avenues for the future. So, as you see here, we have very multidisciplinary team with us, with academics from different disciplines across Finland. And I want to extend my thanks to all members of the organizing team, and also to Finnish Cultural Foundation. Besides, I want to say a special thank you to our chair of this whole project, Assistant Professor Nelli Hankonen, who is currently working abroad in the United States, and unfortunately she cannot be here with us today, but she's saying hello and sends greetings across Atlantic to us. And another special thank you goes to our research assistant, Sarmite Puukko, who has been a great help with organizing this symposium. Sarmite is here. And if you have any questions concerning practicalities of this symposium, please ask me or ask Sarmite. Both of us are more than happy to try to help you as much as we can. As I said, this symposium is part of a larger BeSP project. And here you can see some of the aims of the bigger project. So we aim to advance quality of academic research on influencing behavior change, and to combine aspects from different disciplines to do that. And also we aim to search novel forms of collaboration to improve opportunities to conduct high quality intervention research, and to enhance use of research in designing policy. And during this project, the whole BeSP project, we are organizing 5 symposia. The first 2 symposia with the topics of intervention, evaluation, and field experiments, and behavioral insights in developing public policy and interventions, we already organized last year. And now we are here, nicely in the middle. And in 1 month, we will have the 4th symposium, and the topic will be implementation and dissemination. And then finally, we will have the last 5th symposium next October about complexity approach. And during the next autumn, we will also try to tie the main insights from the symposia together in collaboration with Demos Helsinki. And we will develop a toolbox that serves as a guidance to better use then science and research in decision making. And we had great talks in our first symposium, and also the second one. And you can still actually access all of the recordings of these symposia, so please use that opportunity. And the focus of the whole BeSP project is on the interventions that target behavior. And behavior altogether is crucial to get the target problem solved. So it's important focus there. And this doesn't mean, however, that the solutions would be psychological only, but there are also like different level activities that can be used to intervene. And this means that we need various disciplines, scientific disciplines, to contribute to behavior change. And related to this, we actually wrote with Nelly a short piece on behavior change for a special issue in the Journal of Finnish Society of Future Studies, if you are interested. And different societal problems are approached in different disciplines with slightly different concepts and traditions. And one of the goals of this symposium is to come out of the disciplinary silos and hopefully to have fruitful discussion. The main topic of this symposium today is reverse translation, which has been also understood in different ways. Below are some examples related to research goals that are guided by real-life needs, and that reverse translation begins with such experiences and contrasts with conventional research that starts in the laboratory and ends in a clinical trial. So what is important here is that the information doesn't flow only in one direction, from research to practice, but the flow of information in the opposite direction. So from practice to research is just as important. And today we will have great speakers. Here is the program of today. We will have lunch at 11, and then also a coffee break at 1 o'clock. And the coffee will be served in front of this hall. We also have great session chairs, Professor Taru Lintunen here in the front row, and during the morning session, and then Lari Hokkanen from Demos Helsinki during the afternoon. And besides, what is most important, we have also great and very multidisciplinary audience here today. 2/3 of you are researchers or students from great variety of disciplines. They didn't actually all fit here into my slides, so they are just examples. I was really impressed of seeing how many disciplines we have here. And then 1/3 of you would come from different backgrounds that didn't fit here either. So we have really a multidiscipline audience today, which is really good, because all in all we have really good opportunity to achieve our mission to facilitate interdisciplinary interaction today. So please use this opportunity and interact with each other during the coffee break, during the lunch, and get to know new people, at least one new people during the lunch and during the coffee break, and ask questions and communicate. There is our Twitter handle BeSP, so please use that when you tweet about this event. That's all from me, so welcome and enjoy the symposium.
Good morning and welcome to this third BeSP symposium. You all here who are present today, and also everybody who is following this through the stream. Our keynote speaker this morning is coming from New Zealand. I really appreciate the long trip you made to participate, first to Denmark and then to Helsinki. Our keynote speaker is Professor Krista Fouché. She's a professor of social work at the University of Auckland. Dr. Fouché is director of the Center for Community Research and Evaluation, which builds evidence on promising practices in communities through forming partnerships. She has a joint appointment in the university's Office of Research Strategy and Integrity, where she is involved in the development of strategic research initiatives and researcher development opportunities across the university. Her research and teaching expertise focus on health and chronic illness and on workforce development in the social services. Dr. Fouché's research on workforce development in the health and social services include the migrant professional workforce, with a particular focus on employers' experiences of work and career wellness. Projects in the field of chronic illness build on expertise in HIV/AIDS, AIDS care, and healthcare delivery. She has conducted research and published widely on the creative utilization of community-based sites and practice-based research strategies to enable research that makes a difference in practice. She's passionate about supporting researchers to do practice-relevant research and makes a difference to communities. Please welcome Dr. Fouché.
Good morning, everybody. Thank you so much, Taru, for the introduction, and Elina and others for the invitation to be here today. I must admit it's a very, very long flight from New Zealand, and I've left summer behind. It's 28 degrees and not raining, but it's really lovely to be here to talk about a topic that I'm really passionate about, and to learn from you. When I saw the invitation and the theme for the conference about reverse translation, I was really excited to be part of the conversation, so thank you for having me. That said, when I looked at the word reverse translation, it's really interesting because there are so many concepts that we use when we talk about translating research. So I looked at some of them in the literature, and I started reading on the differences between all these concepts that talk about the differences in terms of how we get results to practice, how we get findings to practice context. And all of these words, concepts, have different meanings, and some people can really eloquently write about that in different ways, what it means when you do translational research rather than implementation science. And it's really interesting. And so I started reading, and I looked into some of these concepts, and then I did a Google search. The top numbers there are the results that I got on Google search when I put those names in. And the bottom ones are the ones that I got on Google Scholar. So basically, there are, even if you go with scholarly research on these topics, there are really literally millions of people writing in this field in terms of translating research, knowledge exchange, and different concepts that relate to that. Now, as I said, we can have a real good debate in terms of the differences and the histories of each of these and the cultural contexts. But for now, I think I'd like to focus on the similarities more than the differences. And what I do find is that all of these things mean different things to different people. But the translation of research to findings, or research findings to practice, seems important to all of those writers, to everybody that debate those concepts. That's really what's at the heart of it. And it's important because it serves the purpose of research, is to make a difference. So that's the bit that I want to focus on this morning, is the bit how we make a difference with evidence and with research. That's not a new thing, though. That as Elena has said in her introduction, it started decades ago in the medical sciences with those discussions about bench to bedside, where medical clinicians discovered that they were coming up with really important medical scientific findings and clinical evidence, but it wasn't really making a difference to service. There was no service improvement. They didn't see the results of really expensive and robust research making into practice. And it was a real issue at the time in the sense that people could get better service if people were just to implement the clinical evidence. And there were lots of questions and debates at the time in terms of how best to do that. Now, we've moved on since then, and it's also entered the social sciences. And I think in terms of the social sciences, we started using the words in terms of evidence or credible evidence and how that impacts and enable us to do meaningful impact. So we're having the same debates, we're just calling it different things and having a lot of different words for it. At the heart of it, it is how we are going to use some of the research that we do to make a difference to the communities we serve. So in that regard, the moment that you start talking about evidence, and if I start with talking about credible evidence in the first instance, we get to that whole hierarchical pyramid of good evidence. And the hierarchies of good evidence always end up with the gold standard at the top being randomized controlled trials and systematic reviews. That's the best possible research we can have. It's the best scientific evidence. And I don't doubt that, and I'm not arguing about that. What is interesting, though, is that the social sciences often fall behind in that regard. So not only are we seen of not doing gold standard research, but a lot of these really high scientific standard research are really difficult to do in contexts and in complexities that enable social researchers to do their work. So increasingly when we talk about evidence, it feels like we need to start thinking about what do we know and what do we want as credible evidence in the social sciences? And how does that differ from this typical pyramid? Now, for me, the pyramid in terms of best evidence and scientific knowledge fits really well with traditional research models that we often see in medical sciences and that we see in the natural sciences, where you have scientists that work on the creation of knowledge. The scientists that work in laboratories and those that do clinical trials, but also those social researchers that do really good research that is disconnected from the practice context. Those research typically and traditionally get disseminated in different traditional ways, and there is then an expectation that there's a group of people that will adopt that at the other end. And that is a really good way of doing research if it is a possibility that you can do that in a way that makes sense to the practice context. However, again, as you've alluded to in your introduction, that's not so easy to do when you talk about behaviour change, when you talk about the context and complexity that sits alongside knowledge adoption. So if we look at that in terms of the where we're trying to have people adopt and implement that science, we're working with organisations and systems, we're working with behaviours and gatekeepers, we're working with powers and inequities and injustices. It's not a clear cut, this is what we know, this is what should happen. And that's really where it gets messy, is that when we want people to adopt, we need to take notice of that complexity, and that's where the real difference can be made if we are embracing that. The issue with that is, though, in the social sciences, that became really powerful when the nothing about us without us movement started. Some of you might know about that in the disability and mental health fields, where people were saying that you can't expect people to adopt science if research has been done without them. So the impetus is that increasingly, if you want evidence to be credible, if you want evidence to make an impact, that you need to include those people who are going to be affected by it in your research plan and in your research creation of knowledge. So if we think about that as the way of meaningful impact, it leads us logically to thinking about how do we think differently about what we so-called credible evidence. To me, it means that we need to expand our understanding and definition of evidence. we need to start thinking about, especially those sort of low-resourced environments, not only in the sense of social service agencies that might not have the time, the resources, the people, the context to do evidence in ways that we might have at universities, but also in terms of the communities that we serve. And I work in different communities, have a number of doctoral students that work in very, very low and difficult areas in Ghana, Kenya, and the Pacific Islands. And some of those environments just are not able to produce evidence in the ways that we've had. But we still need to make sure that it's trustworthy and relevant. I was really excited to see a recent video by the World Health Organization where they have appeased the Kenyan government in terms of providing them with evidence, not in the normative forms that they normally get it, in the sense that there's a census that all citizens complete and that all hospitals do and it goes to the World Health Organization. But they've actually accepted that people would go out into communities and sit down with women and have interviews and record from them how many children they've had, how many of those children are still alive, what did they die of, and that those becomes more reliable evidence in countries where it's not possible to have an organizational structure with the high level of sophistication that we have in the Western world. Those are the same things that we see in our organizations that we work with. If you have practitioners that work in low-resourced environments, the types of evidence that they can get from databases in their own organizations look very different from the ones that we would normally generate. So that is what I think we should be doing, is thinking more about our understanding and definition of evidence. But I think we should also continue to consider the strengths and limitations of a wide range of designs and methods that are appropriate to our practice context and to our partners. Increasingly, designs that are useful to researchers are not so much useful to our practice contexts. And therefore we know that increasingly this is about partnerships. There's a whole push even at universities, I'm sure at your own, as I find it internationally, but certainly in our outside of the world, to have more what they call engaged research. Again, there's a whole word salad of what that means: community-based research, action research, participatory research, community university research, partnerships, any of those sorts of engaged type research. We are being pushed to say we need to do more research that is meaningful and engaging with the communities that we serve. Now, what is engaged research? It's really that sort of research that explicitly bring together groups of people who can combine different perspectives and resources and skills to create solutions to communities. It's no longer acceptable to have those sort of designs that we come up with and take to our communities. And you all know about excellent value practice-based research networks that's been developing in the process, which brought me to Helsinki in the first instance with Ilse and others in terms of our practice-based research networks. So those sorts of engaged research are making a lot of traction and getting a lot of momentum, and it's so fantastic to see. But it comes at a price, and I'll talk about that in a minute. So I think what we're seeing is, rather than the traditional models of knowledge creation leading to knowledge adoption and the difficulties of making that happen, we're increasingly seeing a new thinking around credible evidence. And we're seeing that developed in partnership ways by a lot of different stakeholders and role players. Now, in this diagram, I'm sort of trying to depict how these sorts of players would interact with creating credible evidence. But what I've seen increasingly in the centre work that we do is that these sorts of role players are no longer actually mutually exclusive. We find that a lot of our practitioners are becoming researchers. Our practitioners are doing their own research, they're doing further studies. They are the ones that are collecting the information in a way that make them the researchers. We are seeing researchers that are really embedded in practice, doing volunteer work or doing work that are really practice-based. So it's no longer the sort of researchers talking to practitioners. There's a blurred boundary in terms of what researchers and practitioners are. At the same time, when we talk about so-called service users, clients, patients, anybody that is sort of the receivers of our evidence, those service users are no longer the people we serve. They are increasingly practitioners, they are researchers, they are academics. They are the sorts of people that are passionate about making changes to the lives that are affected by research. And so service users are the people affected by it, but are also the researchers and practitioners. Same for decision makers. We have in the room here people from ministries and people from the media and all sorts of people that make decisions about how to communicate, how to disseminate, how to use evidence in practice. Increasingly, we're trying to get those people on board early on to make sure that we don't ask them after the fact, you know, is there a way that we can implement this? But that they work alongside us in the design and the implementation and the collection and co-construction of evidence, so that by the time we get to communities to make a difference, that those sorts of things are in place. The stakeholders, I've sort of done a clunky box in terms of everybody else. But what I find increasingly is how there are really interesting gatekeepers that we need to navigate in this process. People that have access to data that we don't have, people that can give us permission to do things or get access to communities that we can't normally do. We find that particularly in some of our Indigenous communities where we work with Aboriginal and Maori communities in the Pacific Islands and so on, that it's really difficult to get access to those communities unless you have somebody on board that give you access and that vouch for you. And those trust relationships need to happen very early on. In our world also, ethics applications are really tricky. We need to get a lot of approvals in place before we can do research with communities. So increasingly we find that we need to get some of these stakeholders on board early. We need to get people from our ethics committees, from our universities, from our organisations who can give us the permissions and the compliance to do the research to help us shape that. So basically what I'm saying is that no longer are we sort of designing a project and taking it to practice. We are in practice trying to design, co-create what it is that would make the most meaningful impact. Now by saying that, it's much more messy than other types of research, and some days in my centre I think maybe I should just go back and being a researcher in my office. It's just so much easier. But I think that the complexity of it is really where the challenge lies. It's no longer in terms of how we get evidence adopted, it's how we manage the complexities of these sort of co-created processes. So basically, I think there are some key themes, and Ilse and others will talk more about it, so I'm not going to go into that in any depth. But I've asked some of my colleagues, especially in our Indigenous community, some of my students and colleagues ask me, how do we engage all these people? For people at university, it's not part of our jobs, it's not necessarily funded, you don't have time for it, and it's a huge commitment to do that. And what they say to me every time is, don't engage us when you need us. Engage us because you want to work with us. Don't come to us with a funding application that you want us to sign off on, or with an ethics application that you need a letter from us. Be partners with us long before we get to that point. And that's what I found is that if we embed ourselves in communities and we make those connections, it's easier to do that than to try and do it around a research project. The second point is that we need to develop those networks as a mechanism for interaction and knowledge sharing. It's not a once-off research project. It's an ongoing network of people that you connect with, because the challenge that I find again and again is that if you build these connections around, say, a funding application or a particular project and you don't get the money, you're in quite a predicament, because you've engaged all these people in saying we're going to do this fabulous project, and then you don't get the money, and they all think like, well, how can we trust you next time? So basically what we're increasingly finding is that you need to build those networks so that they're excited and disappointed with you when you don't get the money. But it doesn't matter, because we'll keep on working together and find other ways to do this. Otherwise it just becomes a real aspect of trust for the future. The third part is that we need to allow time for what they call knowledge brokerage activities, which means we need to understand each other in terms of what do we mean by the evidence that we want to create. I still remain amazed sometimes when I have all these people in a room in different types of meetings, how what we're wanting to do, we're saying the same thing, but we mean so many different things by it. So in a way, it is about this long-term connections, relationships, to understand each other and to understand what we mean with the terms that we use. And then lastly, that we locate the evidence within the context of people, that they can make sense of it, within and across organisations, not in terms of researchers talking to one another, but that we all make sense of it in that sort of messy context that we work in. And that's a real challenge, because that is a give and take, in the sense that sometimes you have to give up things that you feel really passionate about because the political climate is not right, the funding is not right, the organisation is not ready for it, the community doesn't want to hear what you're saying. And again, I'm saying it's easier just to do scientific research, but it's the complexity and the messiness that we have to deal with. So basically, a word of caution before I hand over to Ilse and to talk about partnerships more later, is that I think that when we talk about these sort of co-connected research, we need to make sure that it happens in a true spirit of genuine collaboration. And the only way you can do that is you need to look at those things like personal relationships, values, and previous experience of working together. It can't be a once-off in terms of connecting around a research project. It needs to be a working relationship and a network where you can make sure that you can express issues of power, accountability, and resourcing. So that brings me then to sort of trying to build a more advanced picture of this messiness and complexity. Because within this contextual situation where we have these different role players working around co-creating knowledge, we work in a political and economical environment where funding drives decisions. It's funding that's helping us to do the research. It's funding that's helping us implement those decisions. And we can't disconnect our planning and our thinking from those environments. It happens in political cycles. I've seen so often that some of the projects that come to our centre happens at the time in a political cycle when they need to produce evidence so that they can impress the powers to be in terms of giving them funding for the activities they want. There's political cycles, but there's also politics within organisations in terms of what matters, what makes a difference, what we value at this moment in time, what we will be funding, what we won't. And all of those complexities, you can't do meaningful impact without taking note of the real reality that happens in people's lives in terms of funding, where the funding goes for especially low-resourced environments, and the political climate alongside that. At the same time, it's about the ethical and organisational context. So in other words, the organisation would have priorities. They would know where they want to go. They would have a strategic plan. The first thing I ask of my practitioners when we start thinking about co-creating knowledge is, what is your organisation's strategic plan? Where are they planning on going in the next 10 years? It's no use we're trying to swim against the stream. Yes, if we have to, in terms of some of the evidence, contradict some of the discussions, that's fine. But for the most part, you need to align what you're doing with the organisation's strategic plan. Otherwise, you're just swimming upstream and getting nowhere. There's a lot of gatekeepers in that organisational context that can make it really, really hard for people, and it can be really discouraging for any evidence-based project. As I said, the ethics of that is probably one of the biggest challenges that I find. In terms of this real complex environments, there's a lot of conflicts of interest, a lot of boundary issues, a lot of issues in terms of people driving their own agendas for all sorts of different purposes. And again, if we don't have an open and frank environment where we get to know and trust each other, those sorts of projects become really, really tricky to handle. We all sit in context. There's a university's reputation at risk, so the university behind me is saying you can't do that, it's putting us at risk. The organisation is saying you can't do that because it's putting the organisation at risk. It's really tricky when you work in this environment. But again, the point I'm trying to make is not that it's easy, but what I'm saying is if we're after meaningful impact, it's the only way. And what we need to do is focus on how we manage the complexities rather than how we're asking if we can make meaningful impact. Am I still okay for time? Got another 10 minutes or so. So I want to just end up with a discussion about the how-to then, some of the creative ways that we can co-construct knowledge. I find that knowledge becomes more meaningful when it's contextualised. when we can say that this is what it means to people in this context. Yes, we have scientific evidence that spans boundaries and that are applicable across contexts, but if we align it with the goals of the impact that we want to make, if we know what the evidence is trying to support, what are the changes, the behaviour changes, the organisational changes, the policy changes that we want to enable, if we align the knowledge that we create around that, we're a long way to making sure that we get the right things done. Therefore, we'll be able to fit the results to the practice. We'll be able to fit make sure that what we come up with are not so disconnected that people disregard it from the get-go. And therefore, we need to make sure that we respond to an appropriate audience. If we are after policy changes, if we're wanting to enact a change in policy and organisational policy, organisational strategic thinking, funding resources, we need to generate evidence that can impact that, the evidence that will be seen as credible in that particular context, and that we can disseminate that to policymakers, decision makers. If our goal is to change the behaviour of communities that we serve, we need to generate evidence so that we can get to that point where we can actually make a change and communicate it to the right audience in the right way. Now, how do we do that? I've been amazed in terms of some of the things that the practitioners are keeping on telling us is don't come with the normal ways of doing research to us. We hate reports, we hate articles. We don't read them, we can't have access to them, we're not interested in that. We know that you're doing it for your purposes at universities, that's all good and fine. We also don't want you to come with a lot of measuring instruments that we have to complete on your behalf. And we don't want you to access our communities with interviews after interviews. There's quite a challenge at our end at the moment, and people feeling overwhelmed by the different questions and requests they get to access certain communities. Again, like the Indigenous communities, everybody wants to talk to them and want to do interviews and measure that. And it comes from all different directions, and people are just fatigued by it. So they don't want to have any of that anymore. Thank you very much. And at the same time, they're saying that what we have is not valued. We have information that we've collected. Can we work with that, and can we make sense of that? So what we have done is we started working with different types of mechanisms to enable and enforce some of these partnerships and the complexities that we have. And I'm just putting a few examples out there. I'm sure some of you in the room would have many more creative ideas to do that. But what we find is that if we work with these communities, and when we have these different people around the table, they're really into some of the, can we make a video about that? How about we take a series of photographs to depict the lives of people rather than having interviews or endless measuring instruments with them? The whole idea of edutainment is creating a lot of momentum, which means that with all these partners, we're using our evidence to put it in a way that has become an educational and an entertainment engagement at the same time, informing people about facts, informing people about research, while at the same time making it entertaining in different ways. What is interesting that these ways of creative ways to ensure that we reverse translate our research into practice has also become ways to collect information. We've had all sorts of really interesting examples of, and this is probably a whole presentation in its own right, but where people have done performances or used visual arts and storyboards to tell these stories, to say this is what's happening in our community. And that has become the data that we've collected at the same time as that we've disseminated through those ways in terms of how we do that. The most powerful example has been of abused children and young girls that's been raped and not being able to tell these stories in a community, but they've made storyboards, and those storyboards have been put up for adults to see, and that's probably been the most powerful way of collecting and disseminating knowledge than it would have been if we did interviews and wrote a report about that. The second powerful one is that we deconstruct some of these ways that we've traditionally disseminated information and use the reports in more bite-sized ways. Practitioners tell us that they like practice briefs. They like a one-pager that tells you, so what is the punchline? What are the findings? What does it tell us? What do you want us to do about it? or that we can have a little blurb in our usual newsletter that goes out, rather than having it in ways that it's hard to digest. The data displays are amazing with the technology that we have, and how you at a click of a button can get really interesting displays of information. Policymakers, decision makers, managers, and everybody is time poor and saying, give us something that we can make sense of in a very short way. And those sort of deconstructed ways have become really powerful. The same obviously for web-based mechanisms. We all know about how you can use Twitter and Facebook and all those sorts of pages and advertisements. And I think that the digital storytelling way, some of my projects in the centre that we've used is we've made podcasts where some of the service users and the practitioners have told their stories on a podcast. And some of those podcasters make it into the ministries and made it to real decision makers. And they like to say that they've listened to this podcast and they've listened to a real life story. And I think those sorts of ways have made a much higher impact than it would have if we send a policy brief to the minister. And lastly, some of those that are more conversational that we know about in terms of usual sort of workshops or chat rooms and blogs and TED Talks and podcasts for those of us that can do that. The Pecha Kucha, you probably know that 20 slides in 20 minutes has become a real thing in some of our organisations where we do brown paper lunches where everybody bring their own lunch, and we have half an hour together. People just come between meetings for a half an hour. There's a presentation, 20 minutes, 20 slides. You get the message and you go. So you need to really know what you're saying and how you're wanting to impact people if you only have 20 minutes in saying that. And I want to end this sort of discussion about creative ways. I can go on for a very long time, and about the use of traditional spaces. It's interesting how every context, every community has a way to communicate with themselves in sort of traditional ways. Some people would have events in a community hall. Some people would have Saturday morning markets. Some would have, sit around a tree on a given day and all the elders come together. There are different ways that communities talk to one another. And what we're trying to do increasingly is to tap into some of those ways and not find new ways and say, let's do a Pecha Kucha, let's do a blog, but let's sit down under the tree with you, or let's be at the farmer's market on a Saturday morning and see if we can get a group of people together to talk to us about that. And it's been amazingly effective and challenging. So I want to end with a colleague of mine reminding me about the Alice in Wonderland children's book that you all probably know really well, where Alice and the cat were talking to one another, and she was saying, would you tell me please which way I ought to go from here? And the cat said, it depends a great deal on where you want to get to. With Alice saying, I don't much care where, and the cat saying, then it doesn't matter which way you go. So I guess in terms of the goal setting of making meaningful impact, we need to ask ourselves, where do we want to go? Because if it is that we keep impact at the front of our research planning, then that is the way we'll shape our projects, and that's the way that we'll identify our stakeholders and deal with the complexities to make meaningful impact. So for me, where we want to go with reverse translation is we want to get the balance right between us, what is we see as really credible evidence, what does it look like, how do we define it, how do we get it, how do we make sure that we get it in the right ways, and how do we balance that in terms of meaningful impact, in terms of making sure that we are really actually making an impact in the practice that we serve. And that's where I'll leave you for that. Thank you very much.
Thank you, Krista. That is most interesting. Now let's take time, a couple of minutes, discuss with the person next to you or 2 or 3 persons about the thoughts and ideas you right now have in mind about Krista's presentation. You're welcome. Now please finish the discussion, the sentence. We will continue soon. We need to take care of the stream also, and we have only one microphone in the audience, so it might be good.
I'll sit down until you're calling for questions.
Oh, perhaps I ask them now. Okay, everybody. Finish the sentence. And I could hear a lot of lively discussion, so that was most interesting, and it seemed to be very interesting to the audience. Any questions? Anything you would like to ask? Yes, please, the back. And please wait for the microphone to arrive, because we want also those who are following this through stream.
Thank you very much for the excellent presentation. I'm a medical man. I have been doing randomized trials and Cochrane reviews from the 90s, and during the last 10 years I have been working in the Center for Health and Social Economics, and I have developed observational effectiveness studies. I very much agree with you that randomized controlled trials are not able to answer very relevant, they are able to answer some very relevant questions, but they are totally unable to answer a multitude of most relevant questions. And this observational study design, which I have for effectiveness, which I have developed, it might be useful also on your field, but I understand that you have to get information also from the other study designs that do not directly bring information of effectiveness, like for example qualitative studies. But thank you very much.
I don't think there was a question in there, was it? I appreciate your comments, and I agree with you. I do want to stress, though, that I'm not saying we should not keep on doing really good randomized control trials when it's possible and when it's available and when it's necessary. But yes, I agree with you. Increasingly, we're finding that answers can come in different ways, and we need to be open for that. Thank you for your comments.
Hello, I'm Mirja Kälviäinen. I'm a design researcher and a principal lecturer of design, teaching people who actually work on the field in design and media. Have you used, as you had the art-based kind of approaches, have you used any design-based approaches, or are you acquainted with what designers do when they work on the field in the contexts and try to make solutions?
No, not really. I know of that, but that's the beauty of these sorts of collaborative and co-created methodologies, is that you get to meet all sorts of different people. And I've not yet had a designer on my team, so I look forward to working with design teams. But I'm sure that the same applies. And as I said, that one slide with the different mechanisms, we can probably have a session just on that and talk about, creative ways to do things, because I think there's photojournalists in the place and media people that would have very different views on it. For me, it's not about getting an exhausted list, but about being open to different ways that people can contribute. And whether it's design ways, whether it's media ways, whether it's photography, I think we need to be open to those ways. It creates a challenge in terms of funding and competence and ownership and intellectual property and all of that. But if we're open to that, and I'm certainly open to any other design type options, I think it's a good idea.
Lots of opportunities there also. Design probes, sort of diary-based research, and then co-design activities, which
I would imagine.
really are useful for the contextual solution making.
Yeah, I can see that. Thank you very much. That's a really good comment.
Any other questions?
Hi, I'm Marita Törönen, Professor of Social Work It was my pleasure to listen to you because I agree with many of your comments or discussion. I would like to know, you didn't mention really participatory action research, but do you involve participatory action research to your reverse translation?
Yeah. Yeah, when I talked about engaged research, I tried to steer away from all the different types of engaged research, of which participatory action research is obviously one of them. We've used action research in different ways, but there are different models in terms of the steps and the phases of these sort of engaged type research models. I've done a lot of reading recently. There's been a lot of writing around community university research partnerships and how that develops around action research. I feel it's the same way that when we talk about translational research or implementation science and knowledge engaged and all of that, I don't want to get tripped up by the words and the processes and the designs. I think if we embrace the collaborative nature of it, any one of those approaches are great. So yes, we've used participatory action research in the same ways with same mechanisms of creative knowledge creation and dissemination. And I think that's actually what it's about. It's about those engaged partnerships. So yeah, thank you for that.
Hi, thank you for your talk. It was really nice. Sometimes as researchers, we don't necessarily see clearly that engaging with the community would be super beneficial for us in terms of getting publications and getting our research questions answered. But clearly, involving communities and community university partnerships can yield a lot of different types of knowledge. But what would you advise to researchers who are a little bit, I don't know, skeptical of engaging community members or think that maybe it's too difficult? What tips would you give for setting up these university community collaborations?
That's a very, very good question. And as in the introductions, you said part of my role is not as a researcher, but in the university's research strategic office, helping early career researchers to develop their careers. And it's sometimes a real tension to tell them to engage with communities because it's not going to get you promoted. And I do think at the same time what the university values in terms of publications and rankings and all those dynamics that we work in is not really conducive to the sort of engaged type research. You're absolutely right. My recommendation is that you balance the two, in the sense that even with these sort of creative ways of dissemination and so on, you can't get away with not having an article or a publication that serves your purposes. You can do that alongside these sorts of things. What I find is that universities are increasingly catching up in terms of that publications are not the only thing that is good for university reputation and promotion, but it's also, if you can put it under the banner of impact, making a change to communities, putting the university at the forefront of change. If you weave that into your thinking and your promotion and your career, that makes a difference. But I think the main thing is not to connect with communities for the sole purpose of research, because that means that your research is bounded and delayed by all those sorts of things and your publications get impacted. But while you're doing research in more traditional ways, building those networks and communities, because by the time you're sort of in the grey, older stage of life where I am, and promotion and publications are not so more important, all those networks are so embedded that it becomes part of life. It doesn't become a decision that you make. So I think it's a long game. That's probably the shortest answer to that.
I would like to ask one more question and continue what Keegan Knittel asked. What have been the most challenging networks to get in, or interesting, or very special? What kind of experiences, personal experiences you have?
Every project's different. Every project's different. I find, as I said, some of the indigenous communities in our end of the world, as with everywhere in the world, all the minority populations are the highest in the negative statistics, highest health needs, highest poverty, housing, all of those sorts of things. So we need to engage with minority communities to make a real difference. But those communities are the ones that are over-researched, that are sceptic of universities, that are sceptic of, policy makers and governments and so on. So it's always a challenge for me if we work in projects that engage with the poorest of the poor and with the real minorities. At the same time, we've done some really good projects with organisational CEOs and high-level government people, and the politics in that space just overwhelms you sometimes, You can't get anything done because you're just so concerned about reputation and politics. And so every project has its challenges. I've just sort of learned to stand back and embrace the beauty of the mess and try and make the best I can in the circumstances.
Thank you. Our next speaker comes also from the University of Helsinki, and Dr. Keegan Nittle is a health psychologist and university researcher in social psychology at the Faculty of Social Sciences at the University of Helsinki. He's a docent of social psychology and health, social psychology of health, and also from the University of Helsinki. Dr. Nittle has developed several health behavior change interventions embedded in existing healthcare pathways, each of which has involved co-design processes. His research interests center around motivation for physical activity and exploring within persons idiographic routes to health behavior change. And I know that Dr. Nittle had a very short night because he just arrived from Porvoo, where he and his soccer team played a game last night. You're welcome.
Thank you for the introduction, Taru. Everyone here in the back okay? Yeah? Good. So yes, as Taru said, I'm from the University of Helsinki, and I'm a member of the Behaviour Change and Wellbeing group within the Social Psychology department. And I'm going to talk about experience-based design and how we can improve existing services and interventions. So when we start, I'd like you to think for a moment about the last time you bought something online. Okay? You went to a website, you found your product, add to cart. You go to the cart, and it asks you, do you want to add this and this? Do you want to add this and this? No. Buy now. I want to buy this product. You go there, it opens the cart, and it says, now, in order to buy this product, you need to register for an account on our website. Okay. Register for the account on the website. Now we've sent you an email. You need to go to your email and open the email in order to click the link and confirm your account. Okay, go back here. Now, we'd like you to sign up for our newsletter. Would you like to sign up for our newsletter? No, just let me buy the product already. Okay, 10 screens later, you get to the point where you can actually buy the product and the product comes to you. Now, that's great. You were able to buy the product, but is this the best designed service? We were able to buy the product, definitely. And so, in a way, the website does what it's supposed to do. We're able to carry out the procedure that the website allows us to do, to buy the product. Is it fit for purpose? Does the service do what it's meant to do? The answer is yes. And then we can ask a question about this website. How well engineered is it? Is it reliable? Is it safe? Well, we don't really know based on that experience. These two aspects, performance and function and engineering, are two of three core elements of service design. And when you have a service that's designed well, it will certainly allow people to perform the functions that it's meant to do, and it will be reliable, and it will be safe. And this can apply to schools, to hospitals, to websites, and to any other sort of service or function that you interact with on a daily basis. But I ask you a question. Are you experienced? The third aspect of good service design is user experience. And this is sometimes overlooked, especially in the digital world, and also in the worlds of healthcare and education. When I talk about user experience, I mean, how usable is the service? How do people feel when interacting with it? So in the example at the beginning, if you're having to do a lot of extra things, that's not really so usable. And if a lot of things that are not core to what you're trying to do are occurring, that's also not very usable. And if it confuses people or makes them feel unsafe, if there was maybe a dodgy set of links at the bottom of the website, that would be quite scary. And central to this idea of user experience is emotion. Now, with that said, I'm going to talk today about the experience-based design approach, which is developed within the National Health Service in the United Kingdom. And it's a method for designing better experiences for patients, for their carers, their family members, etc., and staff of healthcare units. And this approach can be used to target all aspects of good service design: performance, reliability, and importantly, this user experience. Now, they have some pretty nice resources within the NHS, and if you'd like to download a guide for experience-based design, which is the basis of my talk today, you can go to this website and you'll find a nice guide that can walk you through the process. So within the NHS in the UK, experience-based design has been used quite a lot over the past decade. And it's led to a number of successes in improving clinical treatments, and especially how users of the healthcare service have interacted with the service. So there's some case studies of it reducing waiting times for particular services, or streamlining the process. So if you go for a particular procedure to a clinic, not having you wait around. If you have a set time, you get in, you get your service, and you get out. And that can be done by removing sort of unnecessary steps in the process. It's led to safer environments in some areas. So by asking people in a stroke ward how they felt when navigating around this ward in the hospital, they felt they needed something to lean on, and there weren't handrails in some places. One important factor is increased comfort for patients, and this has been probably the biggest area of improvement based on the EBD approach within the NHS. And just making waiting areas more pleasant by tapping into what people feel when they're waiting around and trying to improve on that. One interesting example is this scale placement. So in one ward in a hospital in the UK, they had a scale, like a weighing scale, that they asked people to go onto that was sort of visible to the rest of the waiting room and to other people in the ward. And a lot of people felt really self-conscious of that. And they never had known that had they not engaged in this experience-based design process. I'll walk through the steps of the EBD approach in a minute, but just wanted to give these successes first. And also helped in some instances with navigating around to different areas of hospitals or different parts of a clinic, especially among people or patients who were not used to being in hospital and things like this. So there are typically 4 steps to this experience-based design approach, and the service designers, of course, in this room are going to be well familiar with these, as will some of the qualitative researchers. The first step is to capture the experiences, to get patients and staff involved, and to help people to tell their stories about what's gone on. The second is to understand these experiences, to find out how they fit together, and to see how they interact with the service. Then, after you have a good understanding of what's going on, you can take steps to try and improve. And finally, you want to measure and monitor outcomes as they occur. So in this first step, it's all about capturing experiences. And experience is really about emotion. So you need to find ways in this capturing experiences step to allow people to tell their stories, because through their personal stories, their emotions are likely to come out. And you need to hear a lot of different stories, or at least some important stories, as we heard from the previous lecture, those that are representative, not necessarily representative, but of the people who are really engaged with the service, to get the full representation of the emotions that might be going around in a particular setting. And in order to do this, you also need a safe environment, a welcoming environment for people to open up, feel valued, and feel that they're on a level playing field with others around them, so that they're more open to sharing their stories. So there are several different techniques you can use to help capture experiences. You could set up someone to sort of observe what's going on in a particular service. You could follow sort of a worker in the unit around for a while, or you could follow a patient's journey, just ask their permission. Can I follow you around and see what happens as you're going through here? You could also use questionnaires about experiences, or have people keep a video diary or a journal as they're walking through. What are you thinking here? What are you thinking here? What's going on now? What are the different steps you're going through? How are you feeling about that? And what's often done also are sort of interviews and focus groups with people who are using a particular service, to allow them to talk about their experiences, to walk through. First I did this, and I was feeling this way. Then I did this, and I was feeling this way about it. Then I did this, and I was feeling this way. And in each of these methods, like I said, you want to be open to what people are saying, and try to really understand, or not understand, but capture their experience. And the best way to do this is to sort of take a step back, allow the persons their space to really tell their stories, keep an open mind to what they're saying, have people demonstrate or show rather than just tell you. If you can get a physical movement along with their story, then it's maybe better. And also watch out. If the environment's not as safe as you think it is, that maybe the person's body language is telling you a different story than their words are telling. And also look out for surprises. Oh, did you see the surprise there? Hey. Yeah, look out for surprises, because in this capturing experiences step, people might be expressing emotions that you wouldn't have really expected at any point in time. So when our web designer designed this online shopping experience for us, he or she never considered how we would feel at some of those steps when we're getting really annoyed that we have to go through 7 different other steps before we can actually do the thing we're trying to do. And you need to look out for surprises, because if you've been involved in delivering a service or designing a service, you see it one way, but the people who interact with the service might see it in another way. And understanding that experience, capturing it, is the first key step in this experience-based design approach. Now, the next point is understanding experiences, the next step. And there are 2 main factors, or three main steps to this. You want to first identify the touch points. Identify where the service users or product users are interacting with the product. What are the key steps on their journey to interacting with the service? So they set an appointment, then they're greeted at the clinic, then they go for the test, and then later they get a call about the test results, for example, would be one journey. So each of those steps are called touch points in experience-based design approaches. And the next part is to identify emotions. What emotions is the person expressing when they're telling their story? And the third part is to connect these emotions to the touch points. At this touch point, this emotion is happening. So here's a quote from a patient who's been referred for thoracic surgery. After being told I would need surgery, I was unsure what to expect. So I went home and got on the internet. And what I read from the hospital website actually sounded very daunting. I had a week until my next appointment. So when I came to see the consultant, I had a little green book which was full of questions and all the stuff I wanted to find out. We went through it all, and I asked him what would happen if I decided to withdraw. So first, identify the touch points. I told I would need surgery. I visited the hospital website. I came to see the consultant. Okay, it's 3 touch points. And there's emotions at each of these. I was unsure what to expect after I was told I would need surgery. It was very daunting, so a little bit scared about it. And at the end, I saw the consultant and I was still considering withdrawing. I was still really scared that I might want to back out of the surgery. So once you see these connections, you then have a roadmap basically for how you can improve the service by improving the emotions that the person experiences at different points of their interaction with the service. And that leads to the third step, which is improving experiences. And this is the most important step in experience-based design. It's really the problem-solving stage. We've identified the problems. At this touch point, these negative emotions are being experienced. So in this step, you want to bring together not only users of the service, but also people delivering the services and other key stakeholders to get them to talk about openly each of their experiences at each of these touch points, and to then try to figure out ways in which the service could be changed to improve the emotional experiences of users interacting with the service. You want to first come up with a lot of different solutions. Brainstorm as many as you can, even off-the-wall solutions, and then later limit them to the things that are more practically possible. And again, watch for surprises. Some solutions that you come up with in these interactions can be new and unique, and something that if you're the person delivering the service, you would have never thought of in the first place. And finally, you need to measure the improvements. You need to have a way to keep track of whether the changes that have been implemented result in the changes you were looking for. So gathering and capturing more experiences periodically over time can help you to keep an eye on what's happening to ensure that they're up to the level that you'd intended. You want to use some subjective and objective measures in this if you can. Know what you want your service to look like. What is a successful experience going through the service? And not only evaluate whether or not the thing worked, but what can we learn from the way the service is now compared to how it was before? And can we possibly apply that in different settings, not just in the one in which this was developed? So here's an example of the head and neck cancer service at Luton and Dunstable Hospital. And this is from this EBD guide. So they first captured the experience. They invested time to get the staff on board with this experience-based design process. They approached patients and built trust with the process and asked the patients to keep journals and photo diaries of their trajectory through this cancer service at the hospital. And they also did some interviews with patients and staff separately on video. Analyzed those, pulled out the experiences and the touch points, and they got patients together then as a group to talk about their stories, both the good and the bad of interacting with the system, and to identify the touch points more clearly. And then they brought patients and staff together to really talk about these and to agree priorities and actions that they could take. Then they created several co-design teams that would each tackle one of the issues that they wanted to approach, and involved patients as equal partners in this. So no expert roles or no one had the upper ground. It was really a level playing field. And it ended up with 43 separate improvements in this one service. Some of them were small, some of them were more comprehensive, and really changed the interaction between the person and the service. And finally, they kept patients involved throughout to measure their experiences and identify some ways to continuously monitor what had happened. And keeping the patients involved, keeping the service users involved, allowed for their enthusiasm to keep coming forward and keep improving the service over time. So service design is really important, both the function and reliability, but also this user experience, which is sometimes overlooked. And when implementing a new service, really check the experience, not just whether the service does what you think it should do, but how people are experiencing that service. Modify where necessary and keep on checking the experience. And think also about how you can apply the things you've learned in this particular case to other cases, because you can learn a lot through this process. So thank you, and yes.
Let's continue. Any questions? Let's continue. Very delightful to hear how eagerly you interact. That's very good. Use the opportunity. Any questions, comments?
Thank you, Antti Malmivaara, National Institute for Health and Welfare. Thank you for the excellent presentation. In medicine, these are called patient-reported experience measures, PREM. And then there is the more proximal for assessing outcome is PROM. It is patient-reported outcome measures, so that even in biomedicine, where we have been very, how would you say, logistic, empiristic, we have found out already in 90s that actually what counts is count is how patients consider how well they have the own perception. This is I haven't heard previously so much about this Prem, but excellent presentation. Do you work with hospitals or healthcare centers or the healthcare field?
Not presently, but in my previous roles in Newcastle University in the UK and in Leiden University in the Netherlands, yes. And mainly to try to find ways to analyze what care is currently being provided in order to implement behavior change interventions more effectively in those settings.
Yes. According to law, we must look at how effective we are in healthcare, and we have very little knowledge about what happens in healthcare currently. We use PROMs. We somewhat use PREMs. PROMs are also, of course, the most important because they reflect how well, how good the treatment has been in terms of effectiveness. But I would very much encourage you to have connections with also here in our nice home country.
Thank you. Hi, Christina.
Hello, I'm Kristina Pate. I'm from the University of Helsinki and working with health promotion. I have a question about dissemination of the sort of obvious to the public, because I also work in healthcare. I'm a medical doctor, and I have also worked with PROMs and PREMs, and especially in healthcare, I think it's different for curing than preventing. In prevention, the PREMs are more important than PROMs. But how do you communicate and disseminate this with the population? Because you are sort of also raising expectations to the services. You understand what I mean? Because it's in care, there's always limited amount of resources, and when you're raising expectations, how do they resolve that in NHS?
I don't necessarily agree that the experience-based design approach is about raising expectations. I believe that it's about for each unit you have in a hospital, there are patients who interact with that service, and they have experiences at each step of the way. Sometimes they're good, sometimes they're less good, and identifying where they're less good and trying to improve should be on the agenda for both patients and the people providing care in those institutions, and also for the hospital as a whole. Seeing how patients interact with the hospital as a whole in a positive way is certainly also a good outcome.
I agree, but I think then we need a sort of a organizational willingness to do that throughout the organization.
Yes,
not
this is something,
because now it's sort of like it's done in like a cancer treatment, it's done in some prostate cancer treatment and some spots, but not as a whole. So I think there is a paradigm shift that's happening actually.
And this has happened. So you can certainly use the experience-based design approach as sort of a grassroots, bottom-up way to improve services. But in the NHS, it was really a huge push from the whole NHS wide. They put a lot of investment into creating the materials and educating staff on how to conduct these sort of experience-based design approach workshops and focus groups to get the most out of their services. And so having a grassroots push for this, in addition to some top-down, this is important globally in our healthcare system, I think is the two-pronged approach is good. You can meet in the middle.
Okay, thank you. Sanna Herkoma, Turku University. Thank you for your excellent presentation. I would like you to elaborate a bit more on the concept of time. If we're talking about services and somehow when I was listening to you and the whole idea of service design, somehow some of the experiences, it was more episodic in a way. How do you interact with the system once you come to the hospital or you meet the doctor? But how about if it's a long-term journey, a year or two? How does service design tackle time spans? It was about systems, the previous question, like how do you incorporate such a thinking into large-scale services, but how about time? If you look at time.
That's a really interesting question, and I think you could tailor these experience-based design sort of workshops to take that time, the whole chronic disease course into consideration, certainly. You'd need patients who have been interacting with that service for a very long period of time. However, they might not remember 5 years ago when they first interacted with the service. So it's important then in chronic disease treatment that you're able to identify people who interact with the service who want to take part in EBD, who are recently diagnosed, medium-term diagnosed, and long-term diagnosed with the particular condition, for example. To understand how they're feeling, the people who have had the disease and interacted with the system for a long time, and how the recently diagnosed people are interacting with it and how they're feeling about it too. I don't know whether that's a full answer to the question, but it can be done, and I think it's important to look at that time perspective.
I'm Lari Hokkanen, I come from Demos Helsinki. I will be chairing this afternoon session for you. We already had really interesting presentations on the morning. I think we already saw the variety of issues that is related to practice-based evidence and knowledge translations. I also think that we touched upon like some fundamental issues like in knowledge translations, like how to make change practices with evidence, how to make evidence impactful, what we need to do that evidence would be impactful in general, and how to make the knowledge translation happen. There are a lot of like theoretical and practical issues like how to build alliances, how to understand different kind of knowledges. We saw that we have like theoretical levels, we have practical levels that are really like applicable to these issues. And I think we will see even more issues that are related to these things. Welcome back, everyone. I hope you had a refreshing break. Now we are going into the final session of the day. We have 3 presentations, 1 general presentation and 2 case studies. As a first speaker, we have Antti Malmivaara from the National Institute for Health and Welfare. He has studied a lot of cost effectiveness and effectiveness of various treatments and rehabilitation. He is also today going to talk about the same issues, how to study and advance effectiveness in healthcare. Welcome, Antti.
Thank you very much, dear chairperson, dear all. It's a great pleasure to be here. Thank you for inviting me to come. I have graduated as a physician from Helsinki University 77 and been a general practitioner and then specialized on musculoskeletal disorders, rehabilitation, and then done randomized trials and Cochrane reviews from 90s. And I've been, before my current task in Center for Health and Social Economics, I have been the Finnish Office for Health Technology Assessment, where we assessed according to scientific evidence what is effectiveness. But now my task is to look how is effectiveness in real life. Here are my potential conflicts of interest. I have no commercial conflict of interest, so that these are related to research and development activities. Huber and others proposed in British Medical Journal 10 years ago that the formulation of health and as the ability to adapt and self-manage things related to biological, psychological and sociological factors, and emphasis was on individuals' ability to cope with life, so that it was a dynamic definition in contrary to WH very static definition, and that you should be perfect in all these, and that's why WHO was also considered the World Happiness Organization for some decenniums. But now ability to cope is the question here. All activities within medicine have an ultimate aim to advance the health and well-being of everyday patients in ordinary healthcare settings, and this has led me to build this real effectiveness medicine concept, which considers that there are 4 levels that one should aim at when optimizing medicine. The competence is the basis of all effectiveness, efficiency, and equality in healthcare. And it is unimaginable that one would have effective and efficient services and fair services without staff competence. So that this is the thing. And moreover, if you think about evidence-based medicine, all the evidence we have on having competent people doing their stuff. So that and Christina Patja is here. She has presented this CANMED's framework from beginning of 90s already in Canada. Competence framework, and as you can see that medical expertise is there in the middle, but you have to be able to communicate, collaborate, manage, advocate health, and also be a scholar to be able to interpret scientific evidence and have a professional way of dealing with your patients and with your peers. And here you can see the Finnish specialist perceived demands for medical expertise. It's the green bar, and as you can see, it's very high. So that on 1 to 7 scale, and uniformly, all experts think that the work demands are very high. And then when you compare with the support from education, the blue bars, you can see that there is quite discrepancy between these 2 bars. This also emphasizes the need for support from education. And then I have one single example of how competence and is related to outcomes. This is about surgical skill in bariatric surgery. It is very demanding bypass surgery for very obese people, stomach bypass, and then surgeon skill has been assessed separately and then compared to how many complications they get. And as you can see, the technically most skilled group of surgeons, 25%, their complication rate is 5%, and then those quite a big number of 25% of less skilled surgeons, their complication rate is 4.5, and so that this reflects how important is the competence, but also it reflects how important is the context. If you think about randomized trials, which one of these complication rates would you take? In randomized trials, you don't usually rate competence in this kind of fashion. Then we go to evidence-based medicine, and randomized trials and systematic reviews are the main thing in evidence-based medicine, and we really must use this evidence because there are so huge number of studies that coming out that no one can follow them, so that this is indispensable. But if you think about double-blind randomized trial, we will get information about the specific effect of treatment. For example, antidepressant molecule. We get information how the molecule helps the patient. But that is, in terms of real life, that is abstract knowledge that doesn't exist in real life at all. In real life, the patient gets always the placebo effect. So that if you count the number needed to treat figures or cost utility estimates from double-blind trials, you make a major error, and it is being made currently at the present time. So that open trials is related to the real life circumstance. 1 year ago, published paper on generalizability of findings from randomized trials in leading medical journals. The journal said that you must put the result in the title. I usually don't like that, but they wanted to have it. It is limited. So that British Medical Journal, JAMA Lancet, and New England Journal of Medicine, 161 RCTs. And I used so-called benchmarking method in order to get only essential points of these. These are not minor points, but things that should be reported or at least should be pursued. And there were very big deficiencies indicating that generalizability of the evidence may be limited. There were very well the biomedical thing, diagnosis, it was very well reported. But then if you went to looking at the behavior of patients and their environment, for example, in Lancet there was one trial on schizophrenia patients, and the only thing you could tell that they are schizophrenia patients. But how can you generalize the information if you don't know whether they are at home, whether they are unemployed, whether they have so big problems that they don't take the medicine at all? So that there is a lot of things to do in randomized trials, and also we should not be so confident in thinking that we are able to produce universal evidence. Of course, I don't say that I don't at all underestimate randomized trials. Looking at the quality, what happens in real world, and this is the thing that has been discussed now, and in this very, very good presentation, I have got very good ideas also for my own work. 1911, there was a Tsar of Russia here, the one who said that how we must do, but at the same time in Boston there was a surgeon named Ernest Amory Codman who started to follow all his surgical patients. And after first enthusiasm in the hospital, he got fired. People were not satisfied with finding out how many complications one gets out of surgery, and it was not few at that time. He had to establish a new own clinic and continued his work till end of his career and did this thing. How is things now today? We found no study that reported that in our hospital all surgical complications are reported uniformly and systematically. There were 5 studies who reported that we take from start of January till end of March, for example, a sample of patients. So that if this is true, and we did a very thorough search, Ernest Codman was ahead of his time, but he was also ahead of our time. So that one of the largest challenges in modern medicine is how to solve the problem of nearly lack of information on what happens for the ordinary patient in ordinary healthcare. And we direly need this information. And we need also information not just for single interventions, but for throughout the clinical pathway. And then benchmarking, learning from peers. Learning from the best practices of peers. It means that we should uniformly record how we are, what kind of patients do we have, how are we treating patients, and universally also outcome criteria, so that we could do this comparison. And here I present the benchmarking control trial. 11 years ago, when I started in my current position, I found that there is no universal framework for observational effectiveness studies. There are frameworks for observational studies, but observational effectiveness studies, which are counterpart of the randomized control trial, so that I conceptualized it and operationalized and tested on Lancet and New England Journal of Medicine papers, which were very good, but there was lack of discussion of many limitations that are inherent for these trials. And here, if we have a single intervention, randomized control trial is the primary choice of design. But if we have very heterogeneous patient groups, for example, if we have cerebral palsy patients that are all different, and we have different kind of rehabilitation interventions, with a randomized trial ending up with one point estimate of effectiveness, you are not able to generalize it to all these patients. And BCT may be a better option. If you want to look at the clinical pathway, how, for example, hip fracture patients fare after 1 year, it's not just the orthopedic treatment, it's the rehabilitation chain and how intensive the rehabilitation is. Benchmarking control trial is the primary choice of design. And if we want to improve our work by performing with other healthcare providers that are treating similar patients, then by definition, benchmarking is the thing. Here is an example of one benchmarking control trial. We compared mortality, 1 year mortality for ischemic stroke patients in 6 European countries. And here are the results. In Finland, you can see that the different healthcare districts, there are 20 of them, they have very different results. So that the mortality, there is 10 percentage points of differences in mortality within Finland. And if you could look at Hungary, very sad results indeed. So that mortality is extremely high. And also very big deviation between the healthcare districts, and also in Scotland they have rather high mortality rate. So that this is one example of a benchmarking control trial. Then very much is speak about what about the systems. We all know that systems are very influential in deciding how many people will die and how many people will have good prognosis versus it is, but it is not so well perceived that if you are under a table and you don't see the patients, that your decisions or not to make a decision, they may be and are decisive ones. In these cases, about healthcare systems, features or interventions, for example, SOTE, what SOTE does for depression patients, what it does for surgical back surgery patient, you need a benchmarking control trial. You can use a randomized trial, but it must be a cluster randomized trial, and it is very, very cumbersome, costs a lot, and gives answer only to one study question. But after 10 years, when you publish it, it may be that it is obsolete already, the intervention. So that here is the thing, that these benchmarking control trials, these are the same as looking at what really happens in the real world, and having feedback instantly for that. So that they are like glove in hand. Research and practice. And there is a example of a system intervention 2006 for those living in Lahti. They got after surgery in the central hospital. They got very good rehabilitation after hip fracture, but those not living in Lahti, they went to their homes and they didn't have this opportunity. And actually, then those living in Lahti, they got home earlier. Hospital stay was smaller, and based on that, also the expenses were very much smaller. So that there was evidence that this kind of system change can really help patients. Then conclusions. What is the best method to study effectiveness? And there is one, clue that John Dewey said that please don't build hierarchies of methods. This is one clue. And I repeat the question. What is the best method to study effectiveness? Depends on study question. I think that this is, and I'm happy that this confirms with John Dewey's philosophy. So that if you have a study question of one single intervention, then randomized controlled trial is usually the best, but not always. But if you have study question of clinical pathway, which is often much more relevant for the patient. Of course, patient is happy when he or she comes home from hospital and things have gone right. But what about if the rest of it is not good? It should be the throughout the system, and then value is created at front line, so that in interaction between healthcare personnel and the patient, even in surgery, it's the interaction between surgical instruments, the surgeon and patient interaction. It is not created by those who are leading the systems. It is always comes from there, and and here I have a view about how on an individual level the effectiveness is cumulative in medical care and rehabilitation, so that always the patient gets information and support. That is interaction, and it can be extremely effective. Then rehabilitation, returning functioning, how to cope in work and how to be independent at home and so on. And then if we have this biomedical, which are most important, then we get that incremental effectiveness benefit plus the placebo benefit. And then if we have information like we have been talking here about what is the real life situation, that I call here benchmarking information, we get even more effectiveness. Of course, these are schematic, these bars here. And then if you think the whole system, then I think that in medicine, and I'm thinking, I have been thinking also about social and healthcare together, the competence. If you think, for example, people that are making decision whether a child should continue home or taken out of home, we understand that it demands extreme competence. So that competence is a sine qua non. It's mandatory to have the competence. And then up-to-date evidence, let us call it evidence-based medicine, and then information what happens really in real life, and we can improve performance. And then when we have common measures to measuring, then we can learn from each other. Thank you very much.
Do we have questions for Antti about his interesting presentation? Anyone? Well, I can start. I thought it was really interesting about what enables learning in a complex world, because it's not restricted to medicine, that if we do like really well-defined interventions, how we can generalize them. So how do you see like if we go from medicine to other like behavioral sciences or social sciences, that what can we learn with like RCTs, for example, or experiments like in a really complex social world, because it's a really big and general question at the moment in the social and behavioral sciences also.
Yes, I think that it has become a bit dogmatic, and that is the problem. And so that I think that one should always do as one has done always, to start with the study question, and then decide whether randomized control trial or whether observational effectiveness study, if your question is about to get information about effectiveness. And then when you have made that decision, then you plan the study according to the best recommendations, taking consideration all details, and then you conduct the study, you make a protocol, you conduct the study, and then again report according to the recommendations. And so that I understand, like someone said, implied here that unfortunately it is so that it is much more easier to publish randomized trials than observational effectiveness studies, and it creates a bias in the scientific field. And of course we personally, it's good to take into consideration that kind of things also. But to start from the most relevant study question is the thing, so that not to follow what someone else shows pyramids and whatever, but to according to own competence and own study group's competence, think what are the most relevant questions, what is the most best study design.
Can I continue with that? I think that there are a lot of experiments or developments of these randomized control trials, where you, for instance, also use have user panels afterwards, or include that. Because you need to also bring into that what does this mean also for the users and so on. But for instance, in Sky's Social Care Institute of Excellence, they've used very fruitfully also of combining different kinds of panels and discussions with that. Also in Norway, they always combine qualitative studies together with the RCTs, and that could also be one way of perhaps getting the learning element more into that.
Yes, thank you. That's a very good point. However, if you think about randomized trials and the huge effort to implement randomized trials, and implementation research is one genre of research. From implement research we know that huge expenses, very little gain. So that a parallel alternative is to develop things and get research out of that development, so that have constant feedback, not just after 5 years feedback after implementation trial. And again, implementation trial answers only one study question. So I am convinced that it is not the only way. It has been considered the major way, and even not considered that there could be an alternative. I think that the alternative is better, because we have the evidence that it does not work.
Thank you, Antti, for an amazing lecture or presentation. My question is about utilizing dynamic system studies and complexity sciences in future studies. You mentioned that there are extensive time series collected during the past decades, and that makes it possible, at least there is a good basis for future research. But do you recognize a need for some certain types of time series that should be collected that have been neglected today?
Yes, again, very good question indeed. And I think that we should very much utilize all those longitudinal data collections that have been done already, and within those then we might find out groups of patients that have got this kind of information, and here they have got that kind of information, and we could end up with good observational effectiveness data. Yeah.
I think we have to go forward now. Thank you, Antti, for your presentation. Now we have a case presentation by Taru Lintunen. She's a professor of sports and exercise psychology at the University of Helsinki, and she's interested most in motivation and behavioral change in physical activity. Welcome, Taru.
Good afternoon. Thank you for introduction. I'm also a great fan of John Dewey and completely agree with Antti Malmivaara that we first need to think about what's the research question and first then choose the method. In my presentation, I concentrate on action research case study method, and my examples come from physical activity contexts, and my research interests today are on social and emotional learning. That's the context where we operate quite a lot at the moment. And social and emotional learning can be divided to areas of self-awareness. Here you see examples of different skills related to self-awareness, like identifying emotions, self-management, for example, impulse control, social awareness, empathy, respect for others, relationship skills, resolving conflicts, for example, and responsible decision-making, ethical responsibility. Quite a broad area. And currently, most researchers are doing research in the area of self-awareness about identifying emotions. But as you can see, this is quite a broad area. And this wheel figure comes from Cassell Collaborative for studying social and emotional learning. They have defined concepts in the field. Social and emotional learning is a process, something that happens on time. So it's about acquiring skills, and you saw this quite a long list of different skills that we can teach, try to learn. And according to research, there are a couple of meta-analyses and research reviews, and they show that education, when we try to teach these skills, we get quite good results. It leads to academic outcomes. School achievement improves. School students' behavior improves. And these impacts are long-term and global. even the return on investment is quite high based on these intervention studies, randomized controlled intervention studies. And the studies can be anything in that area. So if you teach recognizing emotions, that has good effects, and sometimes you have a combination of different skills. So it seems very promising to teach social and emotional skills. In most studies they have been taught to school students or in school or physical activity environments. So we know that programs targeting social and emotional learning are effective, yes. What we don't know is, for example, what's the optimal content of the CIL programs. You remember quite a long list of different competence areas, different skills. What should we pick first? What were the basic skills? Are there hierarchies? How to approach the content? And what's the optimum number and frequency of sessions that should be offered? We don't know about that. There's only practice-based knowledge on that, no research. And what are the characteristics of the most effective facilitators? What kind of instructors we should have? According to meta-analysis, the instructors have mainly been teachers at school or external experts, researchers mainly. And based on results, it seems that teachers are more effective. Maybe they know their students better. Even though, of course, experts know the theory behind and are skillful in other ways. But however the interventions are organized, they seem to work. And the improvements in school well-being are quite high. So most of these studies have measured something at baseline and post-intervention. Some studies are randomized controlled, some don't have control group, and the effects are usually quite positive. However, what happens in between during the process of social and emotional learning, we don't know much about that. And that's something I'm interested in, that part, changes over time. Of course, we need much more controlled trials. We don't know enough of that, but we know enough. The results are very positive, so I think it's worth also concentrating on changes over time, the processes of learning. And we have used action research case studies, and those are cyclic processes where you plan the intervention, carefully pick the skills you want to teach, implement the intervention, and then observe, evaluate. Not so much the results. Of course, you measure also whether they learned and whether well-being increased or whatever you want to measure as the end variable. But we observe, we measure what happens in between over time. The processes are observed and then changed on the basis of the experience gained. That means quite a lot of data, different data gathering methods, quantitative, qualitative, and that needs to happen over time because interaction environment may change overnight. For example, when we studied an ice hockey team where they had major interaction problems, and then they were able to solve them in one meeting. And the very experienced coach and the researcher had never seen that huge increase in performance after just one evening working. So as a researchers, we need to pay attention on the whole process and what happens. It may happen very fast, or it may take time. Learning skills takes time. Social interaction skills are like motor skills. You need to practice them. But then interaction environment may change very quickly. When we plan intervention and implement them, the approach of the researcher is quite abductive. Discussion between theory and practice. And then the analysis phase is inductive. We learn from the process and from the field. So we explore through practical engagements. We make working models, and all this guides empirical explorations. This kind of approach we have used with many target groups, for example, school students, university students, teachers, coaches, athletes, elderly people. Some of them even had memory problems. So we have gathered quite a lot of information. Researchers have often been experts. My students, master students, PhD students, I come from sport and exercise sciences, and our students often have quite a lot of expertise. So they have been able to use it as researchers. I have a couple of cases, and the first case, these are results, just very minor parts from longer follow-up processes. An active listening example is from physical education, where teachers constantly call for better performance and more effort and input. Go on, jaksaa, jaksaa. And in this quote, students is saying, running on this judo mat is really hard. Teacher, sure it is. Teacher reflected back the feeling. And in active listening, you demonstrate concern for and acceptance of the other person, want to understand the other person, restate of what the other person has communicated, thoughts and feelings. And it helps the other person to find solutions, him or herself, express him or herself, and think independently. You should avoid judgments, interpretation, advice, and of course embarrassing the other person. And when a teacher used Marja Kuusela, you can read more in her PhD study, when she used active listening in physical education, the atmosphere improved in class, and students often chose to participate in the situations where they ran out of strength or energy. And that was surprising, because usually if a student runs out of strength or finds something embarrassing, they stop. But when they were heard, they continued, which of course is very positive in physical education, but it was surprising to the experienced teacher. She had never seen anything like that. Students became more open also. The other example is a training program for novice physical activity instructors who used teaching personal and social responsibility model of Don Hellison. And this comes from Hanna-Mari Toivonen's PhD, which is in progress. Protocol article has been published. And the aim was to teach TPSR-based instructor training program for novice instructors, which means young adults who had some personal physical activity or sports background, but no training, no pedagogical or coach training. And this is the group of young people who are now thrown to schools in every community in Finland to organize physical activity on daily basis. We wanted to give them some tools, and Hellison's method seemed to be quite suitable for that. It's a 20-hour training for these novice instructors. And here I just report or show you Bowen's evidence-based framework for feasibility studies, and 4 domains out of altogether 8, but here we used 4: demand, practicality, acceptability, and implementation fidelity of the program. And feasibility was studied to optimize the intervention to determine whether the program should be accepted for further evaluation later for large-scale randomized control trial. And in this case, action research is very useful in the feasibility studies. So here you can see the 4 domains which we studied, and no need to pay attention to the actual results, but just an example where you can concentrate as a researcher when you study whether an intervention program is feasible. And we repeated the program several times. That's part of action research, that you need to organize the intervention quite many times to learn what you can transfer to other contexts and what is unique to this one group. So these were 2 examples to illustrate the kind of approach we have with action research case studies. Thank you.
Yeah, let's discuss once again.
Joo, tuossa edeltävässä puheenvuorossa tuli esille, sorry, in English. The previous presentation, it came out that one should think about the research question and then choose the method to go with it. That RCTs are no golden rule, but you should think about the question. Could you elaborate a bit more on what would be the research question that action research could offer best answers to, if you know what I mean? Like, when would you choose action research? What would you primarily be looking at? Processes you were talking about, but if you would have to choose one question, what would it be?
Yes, research questions deal with for example, the learning processes, whether physical teachers of physical education can learn social interaction skills, how many hours the program need to be, and for example, this kind of questions would be the research question.
And I was thinking, like, those are the similar ones in quantitative approaches as well, that you would look for fidelity.
Excuse me.
In quantitative research, you would probably look in fidelity and the connection between fidelity and outcomes, or you would look the program mechanisms or things like that. So would you say that action research would tap into those same questions, or would it have some other approaches or some other questions that it would offer more insight, maybe?
Yeah, the question, the results can be both quantitative or qualitative. Right. It doesn't matter. It depends on what you are interested in. If there are qualitative changes over time, then your measurement, then, for example, you use often narrative approach, and you get a story as a result. So, for example, the example I mentioned with sport team, that the interaction changed overnight, that result would be narrative story. You can read from Esarovio's articles about that.
In behavioral world, we are not giving a pill to a person which is a tabula rasa. The individual has different capabilities to benefit from the intervention. So how do you control that? Because I think the ability to benefit and the intervention's ability to increase the person's ability to cope is actually what we are measuring, and we should actually know about the initiative stage. So are we adding value to all, or average, or how much? So are you measuring things like that? Because then we would actually look for to whom we especially sort of try to give these interventions when we are in the limited resources. So who is really benefiting the most? Do you ask these kind of questions, and do you measure the ability to benefit from the interventions?
That's a very important question, and either you think in advance based on a lot of practical experience, accumulated experience, who could benefit. For example, the novice instructors might benefit, and based on our results, they really benefited out of training. And of course, the idea is that they can then support school students better than if they go to schools without any training. Then, of course, the beauty of action research is that you gather information about how your target group benefits out of the intervention, and you see whether it works better with one group or another. For example, we are often asked whether there are differences between males and females, boys and girls, and we have not found any difference, or that's not our research question usually, but of course, while you follow these groups, both benefit of training of social interaction skills. Attitudes may be different in the beginning, but that's another question. But both can learn and find them useful.
Yeah, last question there. He was first, I think.
Well, I had a question in mind, but it kind of connects to what she was asking. But it's kind of like trying to define how do you ask the question, why do you ask that question, and then what are you trying to answer? And from a pragmatic point of view, I was wondering, where's the factor of saying, why do I believe that using these methods is going to be the best way? How have I come to believe that is the way? And then what do I do? And are there alternatives that I haven't even got in my view of understanding what is available? And then why do I go back and continue to use what has already been done when maybe there might be alternatives that actually might blow your mind and then throw you off from your whole thing of saying, oh, this is how research is meant to be done. But if it's going to come back to the answer of saying, what is more important here? The well-being of others and helping make their lives being more impactful, or then me having to change my own belief about how I'm trying to address these answers. So where does that get factored then into that learning process and somehow answer what you're asking about through what means we can find these answers? And then what are we looking to explore within ourselves that is limiting us from actually exploring those possibilities we haven't actually considered, so that we are the ones who have to disrupt our own thinking first in order to help others? Any comments on that?
Yeah, that blows my mind out. That's the part of a researcher, because you need to start from somewhere. I think that's my strategy or approach, and why this area in general? Why not something else? That's a very personal issue. When I was at school, I was in Kansakoulu, the old system in Finland, and classes were very large, 40 to 50 students, and there was a lot of bullying, and interaction was very bad. And when I was in teacher training, we got very good training. Finland teacher training is excellent. We learned how to teach, how to organize, how to build structure. But we didn't learn much about how to increase or improve interaction in class. So that bothered me. I continued my studies to clinical psychology, learned a lot of skills, and learned the skills come from whatever source, group theories or social psychology, research on emotional intelligence. But some core skills have been taught. There are history of thousands of years in church, training of priests, for example, in Buddhism. So there are skills that have been used a lot. There is a lot of experience. For example, Gordon's theory of interaction skills is quite a nice package. First, I tried to pick skills myself, but then I found, of course, someone has been thinking this before me, like everything. Someone has already thought about them. So though there was a lot of practice-based evidence which we have used. And of course, at the same time, the modern theories of social psychology, we always start from theory. So self-determination theory, Gordon's theory of responsibility, or Hellison's theory of responsibility, or Gordon's theory. But then we combine that with practice. I might not have answered your questions, but yeah, we can continue later. Long discussion, long path.
Yeah, I have a continuing question to the same topic. I assume that this phenomenon is called path dependency, and it's standing on the idea of that history matters when you're contextualizing your research. Did you have some path dependency study before you started conducting your research, and do you have some models or pointers towards these path dependency models that could be useful in these type of studies?
Good question. There were not many models, so and this case example, I planned to talk about action research. That's why the method came. So now we have discussed about the philosophy and method, the content, and I think that's would be worth another discussion. So sorry to confuse you. My idea was mainly to introduce action research in this talk, but not much. Why we really concentrated on action research was that there was not, when I started doing research in this area, there were not many methods available. Qualitative methods were just coming, and so it's a long history of developing different approaches. Thank you.
I think I should now introduce some random guy onto the stage. Hello, I'm Lari Hokkanen. I'm working at Demos Helsinki. I've been working here for 3 years. I have been working mostly with social experiments and themes related to evidence-based policy. I have a background in social policy. I'm really interested in randomized controlled trials and questions related to how to integrate qualitative and quantitative methods to produce high-quality evidence in policy processes. So today I'm going to talk to you about one idea how good practices from the field could be translated into policy-relevant evidence, and Demos made this kind of framework called Design for Government a couple of years ago, so I will present you that. Demos Helsinki used to be a hyperlocal think tank. Nowadays it's quite international. We try to solve the biggest problems in the world with co-creation processes and using science, so we are independent, but we have normative goals in society. We have recently done quite a lot of stuff around the world on governance, innovation, and themes related to, but I'm going to talk about. I will next tell you like 3 starting points why I think Design for Government framework is needed. Then I will walk you through it briefly, and then I will tell you some learnings from the first application of the model with what we did with one ministry. So first starting point is about evidence-informed policy. I don't think evidence-based policy is a good idea. I'd like to talk more about evidence-informed policy in this case. I think it has 2 sides. First one is about what is good evidence for policy. It's about what constitutes like good scientific evidence, and it's about philosophy and methodology of science, like what is good science, what are good scientific processes. That is really interesting, but the other side is how to use that evidence for policy. And then we are thinking about like the muddy realities in the social world, about all the institutional, cultural, and societal practicalities that are related to the question, how can evidence influence policy, at least in some ways. So my idea is that establishing evidence-informed policy might be a bit more about the boring stuff, the structures, incentives, cultures in the public sector, than about like some technical jargon about robust standard errors in RCTs. It's also important, but we have to think about like the practicalities if we want to like expand evidence-informed policy in Finland and abroad. So I think we all know that the translation of evidence into usable policy-relevant knowledge is not easy, it's not straightforward at all. So we need some kind of like evidence infrastructure and institutional arrangement that connects maybe experiments into the real policy processes. So if we have the scientific evidence and we connect it to the real policy process in the public sector, it actually might influence policy with more probability, bigger probability. But yeah, of course, because we don't want to be technocrats, or at least I don't want to be, it doesn't have to guarantee that evidence can influence policy, but it might have some area in that. And we think that such an arrangement seems to require some kind of knowledge programming practices, sense-making practices between those people who use the knowledge and those people who are producing the knowledge. So that kind of social learning that we have been talking about here today. The second starting point is about practices in evidence-based policy. So if we are thinking about like getting better policies in the end, we also have to think about where do the ideas come from for the policies. It's not only from the science. So when people are talking about evidence-informed policy, it's quite a lot about like evaluation of policies. But we have to get the ideas from somewhere, and we have a lot of good practices going on into the field, and at least in Finland, it's a big question always that we have a lot of good practices, but why can't we scale them up? So we might need some process that translates the good practices we have in the field into evaluated policies, or at least some kind of an evidence. And the third point is about our understanding of experiments. If you talk about some random economist from Watt and ask what does experiments mean, it's our cities. If you go to Sitra, they talk more about like doing like more designer-based, like practical learning that we have been talking about here today. And they might be complementary, but they are usually in distinct camps in discussions. So you can talk about experiments as a research method, or you can talk about like it as like a practical approach to public policy. If we are a complex world, let's just try a lot of things and learn about doing that. So experimentation can be as a like holistic approach to public policy. So here you can see that some guys are talking about experiment as like we like produce hypotheses. We are just doing some kind of things like in a fast way, and then we have like validating experiments where we try to validate hypotheses, and it's all a spectrum, so stuff always drop into some part of that. But anyway, the point is that we have a lot of different kind of experiments, and all of them might have some good sides that we should take into account when thinking about evidence-based processes in the public sector. So sometimes it's easy to see dichotomous thinking about experiments, that you should do like design-based experimentation, or you should do like real science with RCTs. But it might be a good idea to combine those two to enable learning in the complex world. So the idea is that people have interesting ideas and practices, and the question is that actually do they work? Should they be scaled up for policies? So it might be good to test them in an iterative way first, like try to learn the context with qualitative methods, do a lot of stuff and see how it goes, and then test some of them in a robust way, but not choosing our side. And this is actually like the basic idea behind the Design for Government framework. So Demos did this framework 2015, which tries to combine these three like starting points. First one is that it connects experiments to policy processes. The second is it takes best practices from the field and tries to evaluate them. And thirdly, it tries to combine best parts from different kind of experiments. And we applied DFG in 2016 and 2018 in Taika experiment, in which we had 7 promising evidence-based art interventions, and we tried to experiment them. And we had some like learnings from that. So now I will go the process briefly with you through. So first off, we have like some policy problem, big problem, and the idea is that we do a like open application period for best practices. So we try to see what is going on in the world with this area we are interested in. So we try to get the best practices people are doing from the stakeholders, and at the same time we ask from the stakeholders that what is important, what could be important for policy evidence, and we try to do social learning at the start with the stakeholders. In Taika at this point we have 55 best practices. Well, maybe 10 of them actually was good, but we had a lot of ideas from stakeholders about what to experiment. And then the idea, of course, that when we have a lot of good practices from the field, we have to combine it with science. So then we look what does behavioral science say about these practices. So we try to put the best practices and the science together and try to work out the experiments out of that combination. And it's not easy because in the Taika I was the expert review phase mostly as a trainee in demos, and it wasn't easy to think about all these good ideas and then what science says and what to make of it. But when we go to the experimentation phase, we try to do it in two phases. First, we have this exploratory phase where we do with little resources, with qualitative methods. We do a lot of stuff and try to learn that what could be good, what could be transformed into the next phase. So we are in the real world, in the real context, doing those things and try to learn what is important in those contexts that we could experiment in a really well way. And then the idea that some of these experiments from the qualitative phase could go into RCTs. So the point is that we had 7 experiments, and one of them, the hospital clowns, went into the RCT. So our main learning was that not every good practice should be went into the RCT phase. So we can be quite happy with qualitative evidence on some practices. So yeah, the first phase is that we try to learn fast, evaluate as you go. This is the way designers and startups try to test things out, do it with qualitative methods. And then maybe some of them transform into this phase when we actually do some really well-defined intervention. And the idea is that at the end, when these experiments have been done, we take the same stakeholders that we had at the start and tell them the results of the experiments, and we try to in a common way work out what does this mean for policy. So this process tries to combine doing science and listening to stakeholders, and it seems to work in some way. So some learnings from this process. I think it's not good to be fundamental that we should do only RCTs. I might say this point because I'm working a lot with economists, and this is not point they usually like that much. So we should use all kinds of experimentation. One of the main findings was that it's easier to conduct robust evaluation designs for those practices that are institutionally established, like hospital clowns. They know what they're doing. There are a lot of partners, but they know what they're doing. But then there are practices that are they're new or not that established. So then we have to do more iterating experimentation first. We just cannot wait that we can transfer every practice into RCT in a moment. So that, like, the general point is that we should be better in thinking about what kind of evidence we need in what phase and what practices should be taken into robust evaluation phase. So we need to know that what kind of knowledge we need in policy processes, what is enough for what. Because you can develop services with knowledge of varying robust level, but when is something more needed? I think that is the question. And it's possible through science and listen to the stakeholders at the same process, and they're really complementary in this. And the basic, maybe the most important point is that the evaluation results fed into the ministerial recommendation for the sote-uudistus process. So, like, the main idea actually is that this is like implemented in real policy processes. So we are not doing experiments there, and there. We have the policy processes and like the model that tries to transfer the practices like into evidence is happening at the ministries. So we don't have those problems that we should like transfer the knowledge from the like University of Helsinki into the ministries. So that was only the first application of the idea. So thank you for this. Now you can talk and ask some hard questions in a few minutes. Does someone want to ask something from me? Kikan.
Still available there. Do you still have your slides up? Or are they gone away? So you showed the one graph where you had sort of smaller tests with low resources and then slightly bigger tests with slightly more resources and slightly bigger tests, and then sort of a real feasibility or evaluation at the top right-hand corner. Could you walk us through a case example of one type of iteration that you did? Like, what do these tests look like in one concrete example?
That's a really good question, a bit hard question actually. Like the basic learning, one of the biggest learning was that it's not easy to do. So maybe I'll go this through with hospital clowns because they did everything right. So the idea with hospital clowns was that they have established their operations institutionally, but they want to like expand what they are doing. So they are going into like different section of the hospital. So in the first phase, they try to like learn the new practices from the like new section of the hospital, and only after that we had the RCT because they had to do a lot of like modifications to their own like work, like with this little test that we can do like the RCT because it was a new context for them also. So maybe this was one good example. One bad example was we were doing one experimentation with two artists in elders' houses in Jyväskylä, and we had really big problems in turning their like work with the elders into like some more robust because they were just like doing a lot of good things and like turning that everything that they're doing into like more structural like experiment or doing seemed to be really hard. So when we are doing this next time, this is really like the thing that we have to think about more. But like in a basic way, this is like doing like feasibility studies first and then RCTs. This is the same model.
Thank you very much. It's most interesting, and it's good that evidence should be taken into account in policy. But these are extremely complex issues, and I think that one should have a process of securing that what one does in order to get evidence for policy, so that it's high class, it's global high class work. And what comes to economics, Thomas Piketty in his last book said that randomized controlled trials are nice, but they can answer only irrelevant questions in economics. And so that one should really think deeply these things. This bear enormous responsibility. In medicine, 75 randomized trials come out every day. It was 10 years ago, and they don't change practice. So that the basic idea is very good, but the responsibility is enormous, and this responsibility should be met.
Yeah, that's a really good question. I think that was a discussion which we had when the newest Nobels came out, because Esther Duflo, the winner of the newest economics Nobel, said that economists should be more like plumbers, like looking at those plumps, and then somebody else is there anyone who's looking at the whole plumbing system? And this is the place where like complexity theory and like systems thinking comes into place, because it's not only about we should do these reductionistic like well-defined interventions, but we also sometimes have to like zoom out. And I don't think that, I think those are they complement each other. So I don't want to believe that we have to choose systems thinking or RCTs, because RCTs give us good information about like distinct causal mechanisms. And if we drop that out, what do we have? Like some like causal diagrams that somebody has done somewhere. So I think causal system diagrams. So I think we need that like bigger picture on the policy systems because we are living in a complex world, but we also need RCTs because it's it's not the best way, it's one of the best ways to something about causal relations, but that was a good question.
Yes, thank you for your very engaging presentation. I was wondering, also relating to this graph and to this whole process, so when you do smaller scale studies, in order to get to the final phase in that sense, how do you deal with error control, type 1, type 2 errors, and also like risk management? So like, okay, what would happen if we scale this up and everything goes to hell? Like, can you say a few words about these things? Thank you.
That's a good, almost ending question, how we end up in hell. How could I say that? In the exploratory phase, we don't talk at all about like error control, but because it's all about qualitative like approach to experimentation, where we all these practical experiments where we try new things and try to learn like what should be like tested like in a bigger scale with RCTs. But with the second phase, of course, then comes the basic questions about the methodology of RCTs and how can we like control the error rates, like as well as we would like to do that. So then it's just we think about like how to do good RCTs in the second phase if we get some ideas from the first phase into the second phase. But yeah, that's a good question.
How many cases have you done using this method?
Oh, this framework. Yeah. This was the first application. We haven't done another, so it will be really interesting to do. We have done like a lot of experiments, but not like that this will be embedded like in some policy process. So that's why, because we understood that this of a government was like an ideal model, and the first application showed that everything is so much harder than we thought. So we did a lot of things wrong, and we learned a lot. So the second iteration could be really, really interesting to do because we have a lot of learnings now about the process. I think it's now time to thank everyone for participating. I want to thank all the speakers. I want to thank Elina. I want to thank about good questions. It was really interesting because everybody was talking about the same things, but like different levels of abstraction, and that's always really, really interesting. It was a good place for mutual social learning about these issues, how to co-produce evidence and make the world a better place. Thank you.
Thank you for wrapping up, Larry. It has been a great day, and I hope to see you all in 1 month. 25th and 26th of March will be the same next symposium. So thank you. Joo.